Good evening, Prayag. How are you?
Good evening, sir. How are you, sir? I'm fine.
Thank you.
So there are total three attendees. Three students are there, sir.
Okay, I think let us wait for about 5 minutes so that more can join.
Yes, sir. Sure.
How is the rain situation in Surat?
It's you know, there were a red alert before 2 days,
Oh,
before 2 days, and right now it is normal, sir.
oh, I see. Is there any river flowing through Surat?
Yes, Tapi.
Oh, Tabi is flowing through your Surat. Oh, I see. Oh,
Yeah.
oh, so that means there is always a risk of a flash flood also.
Yes, actually, the Surat have the almost good drainage system, so we don't, whenever the flood will come, we are not face that flood situation because the drainage system is too good in Surat, sir.
Oh, I see. Oh, it was done by your collector who was transferred during the time of the plague, is it?
Yes, actually, in 2006, there was a flood came into the Surat, and after that, the whole drainage system has been changed.
Oh, I see. Oh. Surat is the capital for diamond industry, is it?
Yes,
Mm.
there are so many offices of diamond here and there.
And also a lot of, say, I know few Kerala people who are working in Surat as diamond workers.
Yeah.
So,
Oh,
so I think Surat can be considered as the capital of diamond industry in
diamond.
India.
Yes,
Mm.
yes. We have actually textile industry as well.
Which one?
Textile.
Ah, textile. Okay, okay,
Yeah.
okay. Okay, few more students have joined, so
Yeah.
I think we can start the program.
Sure, sir.
Good evening, students. As we have said on the last class, today we will have a case discussion. For to discuss the case, we need a volunteer. Anybody who would like to volunteer? Dash, would you like to volunteer? Subhas is Dash. Somebody who would like to volunteer? Dr. Sagar, would you like to take up the challenge? Anybody who would like to come forward to discuss the case? Unless you expose yourself to this type of discussions, you may find it difficult to discuss during the time of the examination. The mistakes you make now will always help you to perform very well in the examination. So I would request all of you to take up this opportunity to discuss the case and streamline your clinical knowledge. Dr. Patel, would you like to discuss? Anybody who would like to who will volunteer to discuss the case? I'm quite sure Saroj will be ready, but then I think she has been discussing.
Sir, I'm Harshad Sagar.
Okay, very good. Where are you from?
Lisi Hospital, sir, Kochi.
Okay, very good. Oh, I thought you appeared for this DNB in the last examination.
Theory over, sir, practical is pending.
But our candidate, he said he has passed the examination.
No, sir, our theory over, sir, and practical is pending, sir. Theory result is not yet clear.
Oh, I see. Oh. But our candidate who has passed this DM from our institution, he actually appeared for this DNB and he said he has already cleared both. Was it another examination 3 or 4 months ago?
Maybe previous batch, sir.
Oh, I see. Okay. Okay, Sagar, I think let us listen to you. So we'll have the details of the case. I'll try to share the screen with you. Okay, is my screen visible to you?
Yes, sir.
Okay, start.
So, this is a case of 22 months studied to
No,
22 years.
22 male.
22 years old male, studied up to 10th standard. Informant is mother. Presented with a complaint of a blue discoloration of skin and oral cavity from birth, breathlessness from 3 months of age, and worsened since 3 weeks. History of present illness.
Before you go ahead, this patient, this patient, his mother is giving a story that blue discoloration of the skin and oral cavity from birth. So, what are the different groups of cyanotic congenital heart disease pathophysiologically? Pathophysiologically, what are the groups of cyanotic congenital heart disease?
Pathophysiologically,
what is the pathogenesis of cyanosis in different groups of cyanotic congenital heart disease?
one is top physiology.
Top physiology, VSDPS, right? Say VSDPS. VSDPS physiology. Okay, right. 2.
Second is admixture physiology.
Admixture physiology. Example?
Example.
TAPVC.
TAPVC.
Okay, TAPVC. There should be a chamber in which all the blood, both the systemic as well as pulmonary venous drainage must be coming and getting mixed up. There are many examples. One is total anonymous pulmonary venous drainage, and there is common atrium, another is common ventricle, single ventricle, or it could be truncus arteriosus. All are examples. Okay, right. Yes. Third.
Transposition physiology.
Transposition physiology.
Yes, transposition physiology. Very good. Fourth.
Eisenmenger physiology.
Eisenmenger physiology. Fifth.
This is miscellaneous.
Miscellaneous group. In this category come?
Sir, Epstein anomaly.
Conditions like Epstein's anomaly or pulmonary artery venous fistula come under this category. So here this patient is on the first day itself, the child was found to be bluish discoloration of the skin and the oral cavity. So whatever is it a VSTPS physiology, admixture physiology, or is it a transposition physiology, Eisenmenger physiology, or miscellaneous group? Sagar.
Blues discoloration from the birth. It is, sir, probably transposition physiology.
Yeah, most likely transposition physiology. What about admixture physiology?
Yes, sir. Admixture.
Yes, sir. Admixture physiology.
Yes, but the only problem is that admixture physiology, sometimes in a newborn, you may find it difficult to recognize cyanosis because many of them may have an oxygen saturation around 88-90%. And sometimes the cyanosis may not be evident, or it may be only very minimal and you may miss it. But if the mother has recognized a fluid discoloration of the skin and oral cavity from birth, I think most likely you have to think of transposition physiology. It can also be pulmonary arteriovenous fistula, large pulmonary arteriovenous fistula can be blue from birth, and they can have cyanosis, which can be detected by any person if it is a large pulmonary arteriovenous fistula. Sometimes pulmonary arteriovenous fistula can be multiple also. So when it happens, then there can be bluish discoloration. But of the other major groups of patients, groups which can give rise to cyanosis, I think I will go with the transposition physiology. Admixture physiology also can be considered, but usually admixture physiology starts developing cyanosis a little later. So even though theoretically yes, but because of the fact that the oxygen saturation of the admixture physiology may be in the tune of around 90%, where the cyanosis may not be manifest. Okay, Sagar. So you are saying that. Okay, then now go ahead.
Yes, sir. History of present illness. A patient is born out of a non-contiguous marriage. First child, full term, LSCS due to non-progression of labor. Baby cried immediately after birth. Birth weight was 3 kg. Mother noticed blue discoloration of a skin of limbs and mouth and tongue on the first day of the baby. She brought this to the notice to the pediatrician, who after examination of the baby said that everything is normal.
What is the interpretation? When the pediatrician said that everything is normal. Any conclusion that you can draw, you can presumably think. It means that most likely the child is not having a
obstruction at physiology, because no murmur is heard.
No murmur. Usually most of the pediatricians just auscultate, and if no murmur is audible, it's passed off as normal. So when somebody has examined, doctor has examined and said that everything is normal, means there is no loud murmur. If there was a murmur, then the doctor would be alarmed immediately. So it obviously means that there is no VSD-PS disorder, because the doctor who examined initially said that there is nothing abnormal, means there is no significant or loud murmur. It is in obstructive lesions obstructive lesions and regurgitant lesions, you can hear the murmur on the first day, not in VSD or even in PDA. It is in obstructive physiology, RV outflow obstruction or LV outflow obstruction, or it may be in regurgitant lesions that you can hear a murmur. Out of these two, the obstructive murmurs are loud, but definitely much more loud and easily detected. Detectable murmur might have led to the conclusion drawn by the pediatrician that the child is normal. So you can roughly think that most likely the child is not having any significant murmur. Okay, right. Go ahead.
Initially, baby was feeding well. After 3 months, the child started developing breathlessness during feeding. He used to cry during the feeding, which made him blue. The child had head sweating associated with feeding. Mother noticed that the child has a suppressed suck cycle. He had associated swelling of both the lower limbs. So the parents took the child to the nearby by pediatrician, who referred the child to the cardiac center, where the child was diagnosed to have a heart disease and was told to parents that he needs the emergency surgery. Due to financial constraint, the parents declined the surgery. For the next 6 months, the child had a recurrent hospitalization for the episodes of LRTI. At the 8th month of age, he underwent a balloon procedure from the cardiac center. Following this procedure, he had a slight improvement in the breathlessness, but a blue discoloration persisted. His both physical and mental milestones of the development were significantly delayed.
What do you mean? What is the difference between physical and mental milestones?
Physical means, sir, his neck holding.
Yeah.
Plus sitting, crawling,
turning over, sitting, walking, all those things. Okay, right. Mental?
Mental means uh, at the age of 1 or 2 months, they will start staring and making sounds, smiling,
Making sounds may not be a mental
Recognizing
milestone.
mother's face.
recognizing
Recognizing the mother. That's the
Yeah.
first mental milestone that we can think about. Recognizing the mother. Then of course starts talking and all are also mental milestones. But recognizing the mother is the most important mental milestone. Okay, right. Go ahead.
At the age of 1 year, he had a fever, seizures, and weakness of the left upper limb. He was diagnosed to have pus in the brain and had a hospitalized treatment. From the age of 1 to 2 years, he had multiple hospitalization for respiratory infection. He started walking from the age of 2.5 years. Mother noticed that while walking, he squats to get the ready for breathlessness. The bluish discoloration of the skin and mouth gradually increased. He continued to have breathlessness and blue discoloration of a body. At the age of 10 years, he was taken to the another cardiac center where second balloon procedure was attempted, but it was not successful. Child remained significantly symptomatic. Parents were told that no further interventions are possible. He had mild improvement with drugs.
Okay, go ahead. We'll finish the history and go back to the discussion.
So, from 10 to 15 years, frequency of hospital admission reduced. However, he remained NOIH class 3 symptoms, no history of PND. At 15 year of age, he developed a swelling of both the elbow and knee joints. Fluid was aspirated from the knee joint. He also had a headache and blurring of vision. Where his blood was tested, he was found to have significant elevated hemoglobin, for which he underwent a removal of the blood. For the past 6 years, he is getting repeated swelling of both the legs, which is temporarily relieved by his medication. He also had multiple episodes of blood removal. He had an episode of hemoptysis 2 years ago.
What is the purpose of removing the blood?
Sir, cyanotic congenital heart these patients will develop polycythemia, so hyper viscosity syndromes, and so we'll have to do phlebotomy for.
Okay, what will be your guideline to remove the blood?
Sir,
roughly what should be the hemocritic values?
Hemocrite more than 65%, sir. Hemocrite more than 65.
Paxil volume more than 16 is enough. And hemoglobin anywhere, anything more than 20, equal to more than 20. 60 and 20 would be, can be taken as a good cutoff mark to, but if the patient is having symptoms like headache and blurring of vision, even at a slightly lower level, you can do the blood removal. And by how much blood will you remove, and what will be the drop in hemoglobin?
During one setting of phlebotomy, 250 ml of blood.
250 ml. 250 ml will result in how much? What will be the drop in hemoglobin?
1 gram, sir.
1 gram, yeah. So 250 will give only. Sometimes you can even remove a slightly larger quantity, and you can even go up to 500 ml, and you can replace it with the saline, so that there is no hypovolemia, and the patients will definitely feel much better. So we can calculate how much you want to reduce. 1 to 2 grams you can reduce without any problem, and you can have a fluid replacement, normal saline replacement during the time of phlebotomy, so that the volume depletion will not be a problem. Okay, right. Yes.
No history of blackout or clearing of vision. No history of palpitation. For the past 3 weeks, he is having dyspnea even at a rest. He also developed edema of both the feet, which came down with the treatment. No history of a decreased urine output, use of NSAIDs or exposure to COVID infection. No history suggestive of a rheumatic fever at any time.
Okay, we'll go to the next one also.
Antenatal history, history of attempted abortion with some medication at the 2 months of gestation. No history of maternal infection during pregnancy. LSS at full term, weight was 3 kg. Family history, no consanguineous marriage, non-consanguineous marriage, parents healthy, one younger sister, no heart disease in the family. Personal history, non-vegetarian, no habits. Treatment history, he has undergone 2 Banu procedures at the age of 8 months and 10 years. At present, he is on 4 medication, one an iron tablet, one is for joint pain, third medication causes increased urine output. He does not know about fourth medication. Socioeconomic status, low socioeconomic status.
Okay. So now let us discuss the case. So how will you proceed to discuss?
Sir, at the birth,
Whenever there is a congenital heart disease, first you should ask whether it is a cyanotic congenital heart disease or a acyanotic congenital heart disease. So what is the answer?
cyanotic congenital heart.
Cyanotic heart disease. Then second question is you have to make out whether it is a high flow variety or low flow variety.
This is high flow variety, sir.
Yes, it is high flow. Why did you say it's high flow?
Because child is having history of Saccharis cycle plus sweating associated with feeding plus volume overload problem like pedal edema.
No, overload does not mean pedal edema. You can say that patient had features of heart failure because and also recurrent respiratory tract infection suggestive of
pulmonary
high flow group.
High flow.
Okay. So, but then what are the features of low flow?
Low flow cyanosis.
What are the features of a low flow group?
Cyanosis, sir.
No, that is high flow also there can be cyanosis. We have already diagnosed that this patient is having cyanotic congenital heart disease. Then
Scatting history, sir. Scatting history.
Yeah, so one of the history of scatting or scatting equivalence. Then one more.
Polycythemia.
Fatigue, all right. Polycythemia is a feature of all cyanotic congenital heart disease. Cyanotic spells. If the patient is having, if the child is having cyanotic spells, that is another feature for you to suspect that patient most likely it is a low flow category. But people have described that in few patients with even with a high flow, especially patients with Eisenmenger syndrome, some of them may give a story of squatting. Rarely, but it can sometimes happen. This patient is having history of squatting. The mother has said that when he walks around and plays around, sometimes he squats. But then you can give an explanation saying that even in patients, because the initial part of the story is very characteristic of high flow. Can you give any other explanation for that? If the child is not cyanotic and the patient had initial history of increased pulmonary blood flow, and over a period of time the child started developing squatting and started turning blue, then can you give an explanation?
Yes, sir. High flow pulmonary blood flow group turning into SM aggregation.
All right, yeah, but then there won't be any squatting. SM aggregation may not, of course, a small percentage can, yes, but not commonly.
Gastrulization?
Yeah, there is a gastrul VSD where the patient can have a VSD. Over a period of time, the patient can progressively develop RV outflow obstruction, and then the patient may present like pathology of like physiology. So that's something which you can always think about in a child who was given you a story of increased pulmonary blood flow features to start with, and over a period of time, the child started developing squatting and also had some bluish discoloration. Then you can think of this possibility. Okay, right? Yes, go ahead. So you think this is a increased pulmonary blood flow, cyanotic group, and can you mention few cyanotic congenital heart disease where there is increased pulmonary blood flow?
Sir, in Gaucher, cyanosis will be there, sir.
Depending upon how much is the development of outflow obstruction, they can present like pathology of phylum, but usually occurs at a slightly older age group, not at this age. They can present like pathology of phylum like findings. Initially, everything should be everything will be more increased pulmonary blood flow. Over a period of time, they can develop outflow obstruction, and progressively, some of them can even go for a right left shunt. Okay, yes, go ahead.
So this is cyanotic congenital heart disease of a high pulmonary blood flow.
No, I asked you a question. Mention few conditions where there is increased pulmonary blood flow and cyanosis. Some 6 or 7 conditions.
TAPVC.
APVC.
Transposition of
Transposition physiology. Yes, very good. Transposition can be arterial as well as venous transposition. The arterial transposition, and there can be venous transposition where there can be anomalous drainage of systemic veins into the left atrium. But that usually may not give rise to increased pulmonary blood flow. That's the only problem, of course. Transposition physiology can give rise to arterial transposition, can give rise to increased pulmonary blood flow. Okay, right? Yes.
VSD ventricular septal defect class post tricuspid shunt.
But that will not have cyanosis. You can think of single ventricle.
Single vent. Okay.
You can think of all conditions without admixture physiology without pulmonary stenosis. So single ventricle, single atrium, then tricuspid atresia without VSD, without pulmonary stenosis, truncus arteriosus. All these can give rise to cyanosis with increased pulmonary blood flow. And a transposition physiology also, it can give rise to increased pulmonary blood flow with cyanosis.
AP window?
AP window, then they have to develop Eisenmenger.
Okay, sir.
Because initially it will be all left to right shunt and they cannot have cyanosis at that level.
Toxic anomaly, sir.
Toxic anomaly, yes. Toxic anomaly can have. What is toxic anomaly, Sagar? What is toxic anomaly?
So it is like a double outlet right ventricle with differential flow from LV to pulmonary and vice versa, sir.
This actually, yeah, it's a double right ventricle with subpulmonic VSD, and the LV blood is preferentially directed towards the pulmonary artery, and the RV blood is preferentially directed towards the aorta, so that ultimately it is something like a transposition physiology. Okay, right? Yes. So here we are.
Will it come under increased pulmonary blood flow?
That depends. If there is no obstruction, there is no outflow obstruction at the pulmonary level, then large volume of blood will be ejected into pulmonary artery.
Yes.
That depends upon whether there is an obstruction or always the thing which decides the pulmonary blood flow is obstruction and the size of the defect. Okay, right? Yes. So you think that this could be an increased pulmonary blood flow. And what is the pathophysiology?
Increased pulmonary blood flow turning into Eisenmenger, sir.
You think it's Eisenmenger? It's developed into Eisenmenger. You think it is a transposition physiology or admixture physiology? What may be the problem?
Since cyanosis is at birth, so I can think of transposition physiology.
And what is the usual life expectancy of children with transposition? Like, can they survive up to 22 years? What is the survival if they are not treated? What is the survival of patients with transposition?
90% mortality first year.
Yeah, so almost in the first week itself, almost 15 to 20% are dead, and by the end of a year, 90% are dead. So they got a very bad prognosis. But you can think of this possibilities, thinking that he belongs to that the last 10% who have survived this transposition physiology. But in transposition physiology, what will be the most favorable anatomical abnormality where the patient can have a survival?
Large ASD.
Yes.
Large ASD with pulmonary
It's
stenosis.
an outflow obstruction.
Yeah, outflow obstruction. There should be pulmonary stenosis because
Hmm.
that will protect the lung from the flooding with blood, and hence they may not develop any pulmonary arterial hypertension. So, in a transposition physiology, if the patient is to survive, you should think of a good VSD, ISD, which allows the good mixing of the blood, and second, the pulmonary stenosis, which protects the pulmonary vasculature.
So single ventricle physiology is possible in this case.
Yes, you can think of the single ventricle physiology also, especially if the child is having some degree of stenosis, some degree of pulmonary stenosis, the patients can survive. Only problem is that even in single ventricle, it is an unmixed physiology. Very often the cyanosis at birth is difficult for the mother to detect
Yes, sir.
because it's only mild cyanosis, an expert only can detect. But when the mother has detected a cyanosis, I would definitely go in for a transposition.
Sir, another is the tricuspid atresia.
Yeah, tricuspid atresia is actually an admixture physiology, and they also can have cyanosis from first day of life. But then again the same problem because there is a total admixture, and if there is a, of course, I agree with you that if it is a if the child is having associated peers, then they can have little more early cyanosis because the pulmonary blood flow is reduced, and hence the desaturation will be little more prominent. So admixture physiology, if there is a pulmonary stenosis, yes, I think there is a possibility that they can be blue from significantly blue from early the first day of life, and the mother may be able to detect it. So that also I think we'll keep in mind, especially problem like tricuspid atresia with pulmonary stenosis. Okay, right? Yes. Do you think that this is a truncus arteriosus, Sagar?
Sir, first day cyanosis. But it can be, sir, but it's the high pulmonary blood flow.
Yeah, the survival in a truncus is much worse than even transpositional great arteries. It's a very their outlook is very bad, and also it's very difficult to, in the truncus also. Usually, if the pulmonary blood flow is adequate, very often the cyanosis is very minimal, and it may be difficult for a mother, a young mother, to recognize the cyanosis. So the mother recognized cyanosis, I would consider that there was significant cyanosis, and my first priority will be for transposition of great arteries. And is there any other clue for you to think that this patient may be having transposition of great arteries?
Two procedures done.
Yes.
Yeah, there are two procedures done. Two procedures were done, and
And the weight of the baby is also the 3 kg.
birth weight of the baby.
So 3 kg. It is sir, in TGA patients, they are more of the diabetic mother and have a weight more than normal.
Yeah, usually it's a chubby male baby. Say, transposition of great arteries, it is a chubby male baby. So very often overweight male baby, looking very healthy and having a major cardiac abnormality. So I agree with you that this 3 kilogram can also be taken as a point to say that this is more in favor of transposition of great arteries because they have got vasodilation everywhere. The child's growth is very good, and the baby will be more, is more common in males. 4:1 ratio, 4:1. Male babies are more frequently affected, and they're chubby babies. And so that's an additional point for you to suspect that this could be a transposition. Okay, yes. And there are two procedures where one procedure was done with that he slightly improved, and a second procedure was attempted, but that could not be done. But so the procedure in early part may also point towards a possibility of transposition of great arteries where an atrial septostomy was done. Okay, right? Yes. Any other differential diagnosis? Do you think that this could be Epstein's anomaly? Sagar? Or do you think that this can be tetralogy of Fallot? Tetralogy of Fallot. Let us think of single things, simple things. Tetralogy of Fallot. Do you think that this is tetralogy of Fallot?
Tetralogy Hello, sir. Cyanosis on first day is
Okay, yes, cyanosis on first day. 2. Is this more suggestive of
Increased blood flow.
increased pulmonary blood flow? So it's a cyanotic angle heart disease with increased pulmonary blood flow. And
plus,
so
increased blood flow group is not there.
your voice is broken. Are you having any network problems? Sagar, your voice is broken. Can you rectify it so that when you discuss, it is clear to everybody? Okay, he had episodes of hemoptysis 2 years ago.
Yes,
Then
sir. Yeah.
what is the explanation for hemoptysis?
Hemoptysis again, sir, a high flow pulmonary blood flow group, increase pressure on the pulmonary arteries can cause bronchial arteries can cause hemoptysis.
Bronchial arteries. What do you mean by that? He is a high flow group. He is 22 years old. So he started developing hemoptysis only 2 years ago. So what can be the physiology behind that? Pathophysiology. Patient might have developed
Fistulas.
fistulas.
Eisenmenger's.
Yes, patient might have gone in for Eisenmenger, pulmonary arterial hypertension, and secondary to pulmonary arterial hypertension, patients can develop hemoptysis. What are the stages of the pathological changes of pulmonary arterial hypertension? 1, 2, 3, 4. Sagar.
Yes.
Stage 1,
Sir.
stage 2, stage 3, stage 4. And what stage does the patient start developing hemoptysis? It's in stage 1, stage 2, stage 3, or stage 4.
I don't know, sir.
Anybody who would like to answer? What are the pathological stages of pulmonary arterial hypertension? Keith Edwards classification is to 6 stages, but we need not go to 6.
Sir,
but you can
stage
go to
1
to
is
4.
stage 1 is medial hypertrophy, sir.
Very good.
Stage 2 is intimal hyperplasia.
In with fibrotic changes. Yes. 3.
3 is intimal fibrosis, sir.
Intimal?
Fibrosis.
Yes. Intimal and even perivascular fibrosis. Intimal plus perivascular fibrosis. Stage 3. Stage 4.
Stage 4 arteriolar dilatation. No, sir. Stage 4
The
is
plexiform lesions.
It is a complex vasculopathy. It will result in vessel aneurysm, plexiform lesions, and dilated vessels. One can give rise to even thrombus formation and can give rise to hemoptysis. So those patients who progress into stage 4 hypertensive pathological changes can have hemoptysis as a complication. So if you want to interpret the hemoptysis 2 years ago, you should start thinking that the patient must be having Eisenmenger syndrome. Some external noises. Can you switch it off? Somebody who is external noise is coming. Can you mute yourself? Okay, right. Yes. So the presence of hemoptysis in a patient with a high increased pulmonary blood flow indicate that patient might have developed Eisenmenger syndrome. Can there be hemoptysis in a low flow group, Sagar?
Sir, MAPCA can produce
MAPCA
hemoptysis.
can produce.
Very good. The aortopulmonary collaterals sometimes can give rise to hemoptysis. So hemoptysis can occur both in high flow group as well as in low flow group. Yes. Okay.
Sir, can we consider top with pulmonary atresia, sir? So increased blood flow situation can be explained by MAPCA, sir.
Okay, pulmonary atresia. Even pulmonary atresia usually because of the good amount of collaterals and also the presence of PDA. Cyanosis on the first day is a bit unlikely.
Okay.
Otherwise, we can definitely consider that because the only thing is that pulmonary atresia is usually a low flow group. He has got evidence of an increased pulmonary blood flow, a high flow group.
That can be explained by MAPCA, sir.
Yeah, if you think that the MAPCA has overdone it, the lateral flow is so huge that it has usually given rise to an increased pulmonary blood flow. Rarely it can happen. More often it happens when there is a man-made shunt, especially central shunt, which can result in an increased pulmonary blood flow. But I agree with you that there can be a small percentage where the nature itself can overdo it, and there can be increased pulmonary blood flow. That can also be brought into discussion as slightly lower in the list. On the top of the list, we should still consider transposition of great arteries. Okay, right. Yes. Any other differential diagnosis that you would like to discuss? As Saroj just rightly pointed out, Sagar, do you think that we should consider single ventricle?
Yes, sir. But that saturation again, sir, cyanosis will be mild, so mother may not be noticed, as you suggested.
Yeah, if it is adequate pulmonary blood flow, the cyanosis may not be very deep, so that it may be difficult. The child can be cyanotic from birth, but it may be difficult for the mother to recognize it. It may be very mild. The mother recognized means there was significant cyanosis. Okay, so on the basis of the history and all, we think that this is a case of most likely a case of transposition of great arteries, increased pulmonary blood flow, and the patient has started developing. Yes, what happened to the patient? Patient is developed pulmonary arterial vascular changes, and patient is presenting at the moment is having Eisenmenger physiology also.
Yes.
So that would be the full, and the patient has undergone 2 procedures, and most likely both the procedures were attended. One procedure was successful, and another procedure was not successful, and so the patient had most likely atrial septostomy. That is our full clinical diagnosis based on the history. That's the first diagnosis. Second, any other second diagnosis? Do you think that we should consider pulmonary atresia also?
Pulmonary atresia, sir, but high flow pulmonary.
Oh, sorry, not pulmonary, tricuspid atresia without PS.
Again, that's admixture physiology. So again, cyanosis is not that, will not be that.
All right, I agree with you that cyanosis will be there. You cannot use the word will not be there, but it may not be deep enough for a layman to quickly recognize it. Okay, so I think we'll stick to this diagnosis and go to the physical findings. Anybody else would like to suggest any other diagnosis? I think we can consider
about TAPVC, sir. TAPVC will not be.
Yeah, obstructive TAPVC, yes. Obstructive TAPVC can have sometimes significant cyanosis, especially intracardiac variety of TAPVC can be definitely cyanotic. Supracardiac variety without obstruction may not be, may have mild cyanosis, but it may be difficult to recognize. Trivial.
So whether obstructive TAPVC will have a stomy course?
Yeah, they will develop acute pulmonary edema, and unless you do something, they succumb to it. So, possibility of an obstructive pulmonary total anomalous pulmonary venous drainage surviving to this age is practically nil. So, I agree with you that that cannot be considered as a differential diagnosis because the patient has survived up to the age of 22 years. Yes, okay.
Sir, please explain that at birth, what is the pathophysiology which will decide that the cyanosis will be mild or very severe?
Pulmonary blood flow.
Okay, sir. So, sir, so pulmonary blood flow, if more, then cyanosis will be very much.
Very less.
Less.
Because then you are getting more oxygenated blood and it is mixed with less of desaturated blood, deoxygenated blood.
So,
If
sir,
the pulmonary blood
PGA, sir,
Yeah.
sir, in case of transposition of great arteries, cyanosis is very obvious. So, sir, there the flow is more.
But here it is transposition. The pure impure blood is going into the aorta.
Okay, sir. So, sir, other than transposition of great arteries, all other transposition, the cyanosis will depend on the pulmonary blood flow.
Yes. In all other conditions.
Okay, sir.
Admixture physiology or VSDPS situation, all will decide how much is the pulmonary blood flow. You can look at the physiology because if there is a, let us say, the admixture physiology four volume of blood is coming from lungs and 1 volume of blood is coming from systemic circulation, the desaturation will be very minimal.
Okay, sir.
While if the amount of blood is coming from the lung is 2 and the blood coming, the venous blood coming from the systemic circulation is 4 and it's getting mixed up, there will be more systemic desaturated blood mixing with a small quantity of oxygenated blood, and that child will have deeper cyanosis.
Okay. And
So
sir,
ultimately,
then sir, why in single ventricle physiology we are getting mild cyanosis?
you can get that whether the child is having PS or not.
Okay, sir. Okay.
If the patient is having PS, there can be deep cyanosis.
Deep cyanosis. Okay, sir.
But if there is no PS, there will be only mild cyanosis.
Thank you.
So it's the pulmonary blood flow which ultimately decides the degree of cyanosis.
Okay,
Good evening, sir.
Good evening. Oh, we were missing you. I think nice to hear your voice.
Sir, abstinence we are considering here, abstinence.
Sagar,
Sir, abstinence.
Gaurav is telling whether we can consider abstinence. Sagar, what is your opinion?
The signs
Abstinence
of
are,
heart failure.
Heart.
Sir,
In what type of abstinence you can get significant cyanosis? That's the question, because here it was a cyanosis which was detected quite on the first day or second day of life. So what is the abstinence where there can be significant cyanosis?
the RV failure.
Which failure will not be there at birth.
Hmm.
Associated with PS.
Associated with? You're right.
Pulmonary stenosis.
Not pulmonary stenosis, but pulmonary stenosis patients in Epstein sometimes may not even survive. They have a great problem, especially what is the problem of pulmonary stenosis?
After closure of the PDA.
Now, in Epstein's anomaly, if the patient is having pulmonary stenosis, what is the problem?
A very early RV failure will develop.
Yes, very early RV failure, because the RV pressure is very high and the patient is having gross tricuspid regurgitation, and forward flow will be very low because there will be significant tricuspid regurgitation, and unless something is done very quickly, the child may not survive. In Epstein's anomaly associated with the abnormality, not only the abnormality of the tricuspid valve.
Restrictive AFD is there.
No, restrictive AST should be there for the patient to develop cyanosis, because the blood should flow from right atrium to the left atrium. But in Epstein's anomaly, the classical one, of course, is the tricuspid regurgitation. That can be that will be there. But on top of that, some of the patients with Epstein can have structural abnormality of the tricuspid valve, resulting in some degree of tricuspid obstruction. So if the patient is in Epstein's anomaly, if there is associated some degree of structural abnormality of the tricuspid valve resulting in some degree of obstruction, those patients can be significantly cyanotic, because these patients can have much higher right atrial pressure, they can have a good right to left shunt, and these patients can be more cyanotic. So a small group of Epstein's can have significant cyanosis. That's a very small percentage. But most of the patients with Epstein's can have cyanosis at birth, but it won't be very deep. Sagar, what are the patterns of cyanosis in Epstein's anomaly? When does it occur at birth or after a few days, or it disappear or reappear? What is the pattern of cyanosis?
Biphasic pattern.
What is it? And what is the explanation?
I don't know, sir.
Anybody who would like to? Gaurav, you have initiated Epstein's. What are the patterns of cyanosis in Epstein?
Yes, sir. Initially, sir, due to because when pulmonary initially due to higher pulmonary resistance, sir, in the initial childbirth stage, sir, there's flow from the right. There's flow from the AST from the right atrium to the left atrium, sir.
Yeah. So since because of the high pulmonary vascular resistance, there will be more severe tricuspid regurgitation. Right atrial pressure will be definitely higher, and through the foramen ovale or through the ASD, there can be a right to left shunt. The child can be cyanotic. Yes. Then what happens?
So after around 4 to 6 weeks, when the pulmonary vascular resistance comes down, sir, the child cyanosis will improve, sir.
Yeah, when over a period of 2 to 4 weeks, the pulmonary vascular resistance can regress, and that can result in less of tricuspid regurgitation. Right atrial pressure can come down, and the right left shunt can disappear, and the cyanosis disappears. Okay, right? Yes.
And sir, around 15 to 18 years, around 15 to 20 years, sir, there is a progressive RV failure, sir, that is leading on to the final cause of cyanosis, sir.
Yes.
Progressive RV failure.
That depends upon, you cannot give any particular age. That depends upon the degree of severity of abstinence anomaly, and also it can also be abnormality of the tricuspid valve, all contribute. So you can say that subsequently, when the patient starts developing RV dysfunction, these patients can again elevate the right atrial pressure, and that can result in right left shunt, and the patient can be cyanotic again. So there can be a biphasic pattern where at birth the cyanosis, then the cyanosis disappears and then reappears. So abstain is something where there can be cyanosis can be as somebody has rightly said, a biphasic pattern. Okay, right. But here, well, the recurrent respiratory tract infection, those features are not a very common feature of abstinence anomaly, because in abstinence anomaly there is no increased pulmonary blood flow. So
this in abstinence anomaly, this cyanosis will be at the birth or some weeks, sir?
No, it can be at birth, because the pulmonary vascular resistance is high at birth.
Okay.
And after, as Gaurav has rightly explained, after 2 to 4 weeks, it actually disappears because of the normal regression of the pulmonary vascular resistance, and reappears when the patient starts developing RV failure.
And sir,
Okay,
two procedures done that also does not favor abstinence.
Beg your pardon?
Two procedures done. Procedures, sir, at 4 months and 8 years of age.
Oh.
Some procedure has been done.
Yes.
That also does not favor abstinence, sir.
Yeah, that's right. That does not favor abstain. And the procedure, early procedure within a few months of a procedure will go more in favor of septostomy, and may favor a diagnosis of
TG.
transpostomy. Okay. Now we'll go to physical findings.
Sir, some review have written if severe abstinence, then they are planning early procedure, sir. So procedure history is both ways.
What did you say?
Sir, yes, some authors writing if the abstinence is very severe, sir, then they will plan for early procedure, like they will even plan for Fontaine pathway if abstinence is very severe. So early intervention also they are planning in some patients. If abstinence is very severe, then they can plan for Fontaine's pathway also.
Yeah.
So
Fontaine procedure can be done on any heart lesion where you think that you would like to make it a single ventricle physiology.
So intervention at 4 months of age, it can be done in this also if abstinence is very severe. So
here this was a balloon intervention, catheter intervention, not a surgical intervention. So as Sarojis rightly pointed out, since it is a catheter intervention, I would like to think that this could be most like an atrial septostomy, and a possibility of transposition is more likely. If it was surgical procedure, then it's open, because there are many surgical procedures which include surgical procedures to increase the pulmonary blood flow and a shunt, or it can be a initial stage of Fontaine procedure. Fontaine is not done in the 4 months, usually after some time, usually 4 or 5 years, not 4 months. 4 months is too early for a
initial first that Glenn, sorry. First procedure.
Even the first procedure is 4 months is too early. It's too early for a procedure. Okay, now we'll go to the physical findings. Okay, yes. Sagar.
Yes, sir. On examination, general examination, patient is conscious, cooperative, no syndromic features. Weight is 35 kg, height is 155 centimeter, mild dyspnea present, respiratory rate is 18 per minute, central cyanosis severe, saturation of 75% in all 4 limbs, pan-digital clubbing present, there is kyphoscoliosis, bilateral mild pedal edema present, afebrile, no stigmata of infective endocarditis. Cardiovascular examination, extrapericardial examination.
Extra precordial.
Except precordial examination, pulse rate is 78 per minute, regular, normal volume, normal character, no thickening of vessel wall, all peripheral pulses failed, no radial, no radiofemoral delay. Blood pressure
What is the usual pulse in patients with transposition of great arteries?
high volume pulse.
Yeah, high volume pulse. Usually there will be. What is the reason?
Associated PDA or
PDA might have closed even otherwise because of the cyanosis, significant cyanosis. There will be peripheral vasodilatation because there is a hypoxemia which will stimulate peripheral vasodilatation, and patients with transposition of great arteries mostly will have a high volume pulse. Okay, right? Yes.
Blood pressure of 130 by 75 millimeters of mercury in right upper limb, 135 millimeters of mercury in right lower limb. Jugular venous pressure not elevated above the sternal angle, normal wave pattern.
Okay. Can you tell me a few cyanotic congenital heart disease where JEP is important?
Sir, in VSTPS, A wave, JVP may be elevated with A wave.
In the tetralogy of Fallot, usual teaching is that tetralogy of Fallot, JVP will not be elevated. Why
if
JVP
VSD is present, sir, there will be no prominence of AV.
Can you think of in a patient with tetralogy of Fallot, if the JVP is elevated, what is your explanation?
Triology of Fallot.
Aortic regurgitation, systemic hypertension, MAPCAS.
Yes, my systemic hypertension is one. But in a child, systemic hypertension mostly occurs in adults. So in a child, if there is a tetralogy of Fallot and you find JVP is elevated,
VSD is very restrictive.
Triology of Fallot.
Usually in tetralogy of Fallot, VSD is unrestricted VSD.
Sir.
With pulmonary stenosis, atresia.
Yeah.
No, sir, triology of Fallot can be.
Triology of
sir, associated tricuspid valve disease.
What tricuspid valve disease?
Sir, tricuspid stenosis only.
No.
Infective endocarditis.
Well, that's a complication. So this has shown that some of these patients who are having a jugular venous pressure elevation seen in tetralogy of Fallot may be having the septal leaflet of the tricuspid valve must be obstructing the VSD when during diastole, thereby allowing the RV and diastole pressure to go up. Normally, what is happening is because of the large VSD, the RV which is hypertrophied, if the end-diastole pressure goes up, it immediately gets decompressed onto the left side. Here, because of the opening of the septal leaflet of the tricuspid valve such that it partially obstructs the VSD, the VSD becomes restrictive. But at the same time, it is a non-restricted VSD, but it becomes restrictive during diastole. But in systole, it is completely free, and all the right, left shunt, whatever it is, can occur without any problem. So in a patient with tetralogy of Fallot, usually JVP is not elevated. If the JVP is elevated, one possibility is that it may be because of the tricuspid valve is obstructing the septal leaflet of the tricuspid valve is partly obstructing the VSD during diastole. Okay, another explanation. Somebody has already said associated with systemic hypertension. Mechanism. Saroj, would you like to try?
Yes, sir. If hypertension is present, then sir, there will be, sir, Burnham effect? No.
Increase in
right shunt,
increase in right ventricular means there is increase in the right ventricular pressure, sir.
Sir, yes, sir. This here, sir, VSD.
It will increase the afterload, sir.
No.
So,
sir, VSD is non-restrictive. So, sir, the effect of the hypertension will come on the RV. So, sir, there
that's
will
right. Even before that, you can say that there can be effect on the RV, but you can also there's effect on the LV also.
Yes, sir. But for JVP, sir, the RV has to be
Yes, so when the effect is on both the ventricles,
Hmm.
RV and diastolic pressure goes up, and RV may not be able to decompress onto the LV because the LV and diastolic pressure also goes up.
Yes, sir.
So both the ventricles and diastolic pressure goes up, and that will result in JEP elevation seen into the neck. So in patients with systemic hypertension, you can have associated JEP
JEP.
in a patient with tetralogy of Fallot. And as you rightly said, a small percentage of patients with tetralogy of Fallot can have a restrictive ESD, and they can also have an elevated JEP. So JEP elevation is not a very common phenomenon, a common finding in tetralogy of Fallot. But if you think it is tetralogy of Fallot, the explanations are one. The tricuspid, the septal leaflet of the tricuspid valve may be partially obliterating the VSD. Two, it may be because of systemic hypertension, and three, maybe that there's a small percentage of patients with tetralogy of Fallot can have a restrictive VSD. Usually, it is an unrestricted, it's a large VSD without any restriction. Okay, right. Go ahead. So JEP is not elevated. Okay.
Precordial examination.
So the question remains, sir. Importance of JVP in congenital heart disease. Sir. That question is still unanswered.
That question is not answered. All right. Okay, Sagar, what are the congenital heart disease where JVP examination is important?
Tricuspid atresia, sir.
Very good. Tricuspid atresia. What wave is important?
A wave.
A wave. Yes. Very good. Excellent. Two.
Epstein anomaly.
Epstein anomaly. What wave is prominent? Epstein anomaly is correct. Which wave is prominent?
And here the column will be
There's-
raised. B wave will be prominent.
B wave prominent. What decides the prominence of the B wave?
Sir, but here the RV contraction is not very good. So, sir, it will be elevated.
Why contraction is not very good? It can be good.
Sir, because sir, here the RV is so there is a atrialization of right ventricle.
Okay.
So RV is rudimentary or small.
Yes.
So, sir, tricuspid regurgitation is present,
Yes.
but it is not very forceful.
That's right. It's not a hypertensive tricuspid regurgitation,
Yes,
because
sir.
if the pulmonary vascular resistance, if it regresses satisfactorily,
So
then
V column will raised, but it will be. Can I say that it will be not very prominent? Raised.
V wave is if it is seen, that may help you to think that it could be Epstein's anomaly, but it usually happens if there is a restrictive ASD or no ASD.
Sir, in Epstein's anomaly, they say that RV is very much RA is very much dilated, so we significant pressure changes will not be seen, sir.
Yeah, that's right, because the RA is dilated. But when there is no, whenever there is no ASD, sometimes the regurgitant volume coming to right atrium may reflect into the jugular veins. I fully agree with you that if the RA is huge because of the atrialized portion of the ventricle, very often it can be compliant, and the V wave in the JVP is not a common phenomenon. But if the V wave is present, then that is a point. That is a point.
Is either restrictive or very small.
Yeah, that is the only situation where you can think of a possibility of Epstein's. That's all. And also you should simultaneously think that there is no ASD or a ASD is restrictive. The V wave is not a frequent finding in Epstein, but if it is found, then this can be a possibility. Okay. Any other wave important? Okay, I think these are the two important waves. Okay, go ahead. Sagar.
So pulmonary atresia with intact ventricular septum.
Yeah, pulmonary atresia with intact ventricular septum. That's very important. Yes. What will be the prominent wave?
Prominent A wave.
A wave.
And A waves.
Can be A wave, can there be a V wave also?
If such
When-
tricuspid regurgitation is present.
Yes, they have usually will have associated. How does if the patient is pulmonary atresia with intact ventricular interventricular septum, how can there be the drainage of the blood coming to the right ventricle? What is the normal pattern of drainage of blood coming to the right ventricle?
Right.
Anyone of you?
Yes. Sir, there
That
is
is
a
right
Sir,
coronary
ASD,
arteries.
sir.
sir, there is a Thracian veins prominent, and sir, the venous system intramuscular, sir, they become very prominent, sir. The sinusoids, and then the backflow to the sir, right coronary artery.
Yeah, the sinusoids of the right
Coronary
ventricle, sinusoids of the right ventricle become very prominent, and through that it can drain into the coronary venous system.
Yeah, yes, sir. Yes,
And
sir.
also they can have some degree of tricuspid regurgitation also, thereby it can regurgitate into the right atrium. So these are the two methods. One is regurgitation into right atrium, and through the sinusoids it can drain into pulmonary veins. So this can have some degree of tricuspid regurgitation, and you can always consider a possibility of a V wave in the neck. Okay, right, yes. Okay, any other condition?
Cotriatum dexter, sir.
Okay, how does it, how can it give rise to waves in the neck?
So again, there is membrane in the right atrium,
Okay,
It will
so it
behave
can
like a tricuspid
give rise to
stenosis.
prominent V wave system.
I do not know whether because why should it give rise to prominent V waves? It cannot give rise to prominent V waves. If there is a septum and septum is obstructive and the contraction that can should give rise to an A wave. How can there be a V wave? I not recently read
Impaired
about.
feeling of the right atrium.
Beg your pardon? I not recently read about the.
It may impair the.
It may impair the. You cannot have a V wave. Only thing is that you have to consider whether there can be an A
venous
wave or
feeling,
not.
sir.
No, I had to read and find out where does this is see the in patients with the poor triatriatum. Usually the pulmonary veins drain into upper chamber, and the part of the left atrium which is there from the.
Sir, it will behave like a TS, sir. Sir, it will behave like a TS.
No, it will not behave like a PS. It will behave like a tricuspid. Yeah, it will behave like TS.
TS.
It will behave like TS, so you can get a prominent A wave.
Yes, sir.
That will be the phenomenon, not
Yes.
B wave, but you can get a prominent A wave. Okay, so these are the few conditions where you can, out of that, most important is tricuspid atresia. Whenever you see a prominent A wave in the neck, you should always think of the possibility of tricuspid atresia in a cyanotic child. Sagar, how will you differentiate between A wave and the B wave?
Yes.
How will you differentiate A wave from B wave?
So before the first start sound, it's a A wave. After that, it's a B wave.
Okay, the one which occurs with the first start sound, or the one which occurs with the before the carotid pulse, before the first start sound, so before the carotid pulse is a wave. The one which occurs after the first start sound, after the carotid pulse is a B wave. Okay, okay, yes. And also from the character, can you make out? You are not palpating, but when you're looking at it, can you make out?
There are two pulsations seen in the JVP, whereas in carotid only one pulsation will be
No,
seen.
it is not the differentiating between carotid and the jugular pulsation. They are differentiating A and V wave in jugular pulsation by looking at it, not palpating. A wave will be a sharp rise and a sharp fall, and B wave will be
Slow rise and
slow rise and
Sharp fall.
sharp fall. Okay. It will be slow rise and a sharp fall. So if there is a sharp rise, sharp fall, it is an A wave. If it's a slow rise and a rapid fall, it is a B wave. And what is the condition in which the Y descent is not sharp? What is
Stenosis.
tricuspid?
Stenosis.
Very good. In tricuspid stenosis. One more condition.
Sir,
Any
right atrial
mass
myxoma?
obstructing the flow? Myxoma, Paul wall thrombus.
Okay, okay.
Or dilate RSOE compress.
No. Okay. If there's any tricuspid valve obstruction, that can give rise to multiple reasons. Anything encroaching on the tricuspid valve, the sinus of vessel aneurysm can encroach on the tricuspid orifice. Or if there is a tumor, lipoma, or some tumor which is obstructing the tricuspid valve, and classically the tricuspid stenosis can give rise to delayed Y descent. Okay. One more condition. Y descent is depending upon what is it? Does it depend upon the RV function?
Okay. RV failure also, sir?
Not RV failure.
Diastole.
Reduced compliance and
Yeah,
reduced relaxation of RV.
Yeah,
RV
cardiomyopathy.
RV relaxation is impaired. If there is an impaired RV relaxation, then the Y descent will be slow. If there's a very powerful RV relaxation, then there will be very prominent Y descent because of the sucking effect. But if the RV function is impaired, especially the relaxing property is impaired, that can result in a
Endomyocardial fibrosis.
endomyocardial fibrosis. Usually, initial part is good. Usually,
Starting tamponade.
in any condition where there is a significant hypertrophy of the tricuspid of the right ventricle, which impairs its relaxing property. Especially in a patient with severe pulmonary stenosis, if the RV is significantly hypertrophied and its relaxing property is impaired, then the Y descent can be less striking. So, of course, first one is tricuspid stenosis, tricuspid valve obstruction, and followed by impaired relaxation of the RV. Okay, right. Go ahead. Yes, Sagar.
Inspection and palpation.
Oh.
Inspection and palpation. Shape of the precordium, pectus carinatum.
What does that mean?
Apex beat visible.
No, don't go away. Pectus carinatum means?
Pectus carinatum is
funnel shaped chest.
bulging, sir.
Bulging, sir. PGF.
Yeah. What does that indicate? Usually it happens in patients.
It indicates the high flow for pulmonary blood flow.
Yeah, usually indicates high pulmonary blood flow.
Congenital heart disease with a high flow.
With the recurrent respiratory tract infection is the group of patients who present with pectus carinatum. Yes, okay, go ahead.
Apex beat visible and palpable in 60 left intercostal space, 4 centimeter lateral to mid clavicular line. Diffuse and forceful. RV type. No thrill, no sounds palpable. Parasternal hue present. Second heart sound palpable in the second left intercostal space. No suprasternal pulsation. Epigastric pulsations are felt of a RV pulsation. Percussion. No abnormalities detected.
No, don't go away. Don't go on to the reading. Here it is an RV apical impulse. What are the conditions where you will suspect if it is an LV type?
Yes, sir.
If the apex beat is LV type and cyanosis conditions.
LV types are single ventricle.
Single ventricle.
Endocardial cushion defects.
Plus top with AR, top with.
To some extent, top with AR.
Top with AR. Top with hypertension, top with MAPCAS.
Yes, and MAPCAS. All right, okay. Top with systemic hypertension, aortic regurgitation, and to some extent, significant increased pulmonary blood flow because of the artery venous, aortopulmonary collaterals. Okay, right.
Tricuspid atresia.
Tricuspid atresia, very good.
Tricuspid atresia.
One or two more conditions. You said most of it, two more.
Pulmonary atresia with intact ventricle septum.
All right, to some extent. Okay, right. Yes. Pulmonary atresia with intact ventricular septum. Truncus arteriosus.
Truncus, sir.
Yes, truncus arteriosus, and restrictive VST in a double outer right ventricle. In a double outer right ventricle, if the VST is restrictive, then you can get an LV apex. So these are the few conditions. Sagar, please repeat. Conditions you should suspect when there is a LV apex with cyanosis.
Single ventricle.
Single ventricle.
Single ventricle.
Yes.
Top with AR, top with hypertension, top with MAPCAS.
Okay.
Tricuspid atresia.
Okay.
Pulmonary atresia with intact ventricular septum.
Okay.
Truncus arteriosus.
Okay. And
DORV also, I think.
DORV.
DORV
with
restrictive VSD with DORV.
The restrictive VSD, and also
endocardial cushion defect.
Endocardial cushion defect. So these are the conditions, where a number of conditions where you can get an LV apex with cyanosis. Most of the conditions there will be an RV apex. Okay, right. Go ahead.
Sir, here that RV retraction we have not written, sir. Type of retraction, sir, diffuse and forcible, that medial retraction, or that they have not written here.
Yeah. Most likely there must be, it must be there because it's written RV type. Okay, anyhow, we have got a clue that the apex is found by the right ventricle. Okay, right, go ahead.
Right ventricle.
Yes.
Auscultation. S1 heard.
No.
Yes, sir. Auscultation. First heart sound heard, normal. Second heart sound single, loud in pulmonary area. No S3, S4. There is a constant ejection click audible in a pulmonary area.
Okay. What are the mechanisms of single second
Murmur.
sound? No, don't go to murmur. No. What are the mechanisms of single second sound?
Yes, sir.
What are the mechanisms which can lead to single second heart sound?
Yes.
Atresia of any of the wall.
No, you should give a mechanism and then tell the condition.
Truncus.
Yes, truncus. You should say single valve.
Yes, sir.
Single valve. So truncus.
And sir, transposition of great arteries.
No. In this itself, single valve. One you said truncus. Another is
sir, like stenosis of any of the valves. Severe.
No. Cyanosis is not enough.
Atresia of the wall.
Atresia should be there.
Yes, sir. Yes.
Pulmonary atresia. If you want, you can include even aortic atresia. So atresia, truncus with atresia, the single valve. Okay, two.
Sir, any anterior-posterior position, one behind the both wall, anterior-posterior position.
Very good.
TGA.
Mostly if the pulmonary artery is posterior, then you can hear only the aortic component. The pulmonary component is not audible. Example?
TGA.
Very good. Third mechanism.
Both valves closing simultaneously.
Yeah, both the valves are closing simultaneously. Example? Example.
VSD Eisenmenger.
Yes, VSD Eisenmenger. Very good.
Eisenmenger.
Yes, very good. Fourth mechanism. What is the mechanism in
Severe stenosis of aortic valve. Severe stenosis of aortic valve or pulmonary valve.
Yes, severe stenosis of the aortic valve or pulmonary valve. What is the mechanism?
Because of the dilatation of
A2 is masked or P2 is masked.
Yes, sometimes a murmur may be so long that A2 or P2 may be masked one, or it may be that the valve is so dysplastic or damaged that the movement of the valve is so restricted that it does not give rise to any closing noise. Okay, especially in Newnan's type of dysplastic pulmonary valve, you may hear only one sound. The aortic component only. The pulmonary component may not be audible. And sometimes in severe aortic stenosis, the murmur is so long that it may engulf the pulmonary component of second heart sound and it will not be audible. And another reason is that sometimes in very obese and thick chest wall people, pulmonary component may not be audible, especially in emphysematous patients. Sometimes pulmonary component may not be audible. So whenever you are hearing a single sound, you should think what may be the mechanism which has resulted in a single second heart sound in this patient. Okay, right? Yes. What do you mean by constant ejection click, Sagar?
Constant. Don't know, sir.
No respiratory.
Vascular click.
First, you should say what is constant ejection click. Then you should say what are the situations you can get a constant ejection click.
No respiratory variation.
Yeah, no respiratory variation. The click is audible with the same intensity during inspiration as well as expiration is considered to be constant ejection click. Or you can say non-phasic. There are many words: constant ejection click, non-phasic ejection click. Okay. So, what are the conditions in which you get a constant or non-phasic ejection click? Sagar. What are the conditions which you get? Can you get a constant ejection click and the aortic valve?
Yes, sir, we can get it when the vessel
Yes,
is
sir, can be.
dilated. Like, sir, in case of
Dilated with.
like idiopathic pulmonary artery hypertension, systemic hypertension because of the aortic cause, and
yes, you are right. All the aortic clicks are constant.
yes, sir.
Whether it is due to a
Vascular
valvular click or vascular click, both are constant. On the pulmonary side, vascular click is constant and valvular click is phasic or inconstant. So whenever when you are hearing a inconstant or a phasic ejection click, then you should think of a vascular click, valvular click on the pulmonary side.
Yeah.
What is the mechanism, Sagar? How is it the click becoming phasic or no? How is it becoming phasic or inconstant? Mechanism.
So here it is constant click, sir.
No,
here
that's right.
It is a constant click.
Yeah, here it is constant. But I am asking a question: what is the mechanism of inconstant click or phasic click? Hemodynamic mechanism.
So constant click. Actually, normally whenever the valve closes, there is some sound is there. But whenever there is a dilatation of the vessel, at that time that sound get pronounced. So that's why we are able to hear the constant click.
That's right. No, I am asking a question. What is the hemodynamic mechanism? Why in pulmonary stenosis the click becomes phasic?
Because this is because of hangover time, sir.
No. It's not due to hangover.
Sir, in pulmonary stenosis, there is a right ventricular hypertrophy. Hypertrophy is there, so there is increase in right ventricular end-diastolic pressure, sir. So during inspiration,
you are right.
It will take time for pulmonary valve to pulmonary pressure to overcome the RV pressure. As a result, sir, pulmonary second heart sound will be delayed.
So what? The question is why there is a phasic click. Question is different. What is the mechanism, hemodynamic mechanism of phasic click in pulmonary stenosis? You were right.
It is the excursion of the pulmonary valve.
Sir, so when there is,
which decides the click.
No, you are.
Sir, when there is increased.
Are you Egnath?
Nikhil, sir, Nikhil.
Nikhil, you are in the correct direction.
Sir, when there is increased blood flow,
so during inspiration, what happens? There is increased venous return to the
RV. So
RI and RV. Okay. So when there is a more volume of blood is coming to the RV, what will happen to RV and diastolic
so
pressure?
RV end diastolic pressure will be high, and sometimes it is more than even the pulmonary artery pressure. So sometimes it not even closes the pulmonary valve.
Does it happen normally? You should give one more explanation. In a patient with pulmonary stenosis, what happens to the RV?
RVH is there, sir.
Yeah, RV hypertrophies. And so
Yes,
when
sir.
there is a large volume of blood is coming to the RV and diastolic pressure significantly rises. And as you rightly said, it may even exceed the pulmonary artery
pressure,
diastolic pressure, resulting in either doming of the pulmonary valve, or even pulmonary valve may open towards the when there is when the right atrial contraction. And because of that, the pulmonary valve is already domed, or pulmonary valve is already partially opened. When the RV contracts, there is no ejection. I will repeat. In a patient with pulmonary stenosis, the RV is hypertrophied. During inspiration, there is an increase in the venous return onto the right atrium and consequently into the right ventricle. So during when the large volume of blood is coming to the right ventricle, that will result in a significant increase in the RV and diastolic pressure in a ventricle which is already hypertrophied. And in pulmonary stenosis, this can happen. And when the RV and diastolic pressure increases, it may increase to such an extent that may even equal or even may exceed the pulmonary artery diastolic pressure, resulting in a doming of the pulmonary valve or partial opening of the pulmonary valve during the atrial contraction. And when the RV contracts, there is no more sudden opening of the valve and the click is absent. So in a patient with the pulmonary stenosis, you can get a basic or inconstant ejection click, while in aortic, all the aortic clicks and the vascular pulmonary clicks are constant. Okay, right. So here is a constant click. So you have to think whether it is a aortic. How will you differentiate whether the click is aortic click or pulmonary click? Constant click.
First is site.
Yeah.
Sir.
What is the site?
Aortic click can be heard at apex also.
Yes, aortic click can be heard at the apex also. It can be heard sometimes on the right side of the sternum, even left side of the sternum. Yes. Pulmonary click?
It's localized to the second pulmonary.
Yeah, it is usually localized. And in what condition can you get the pulmonary click at the apex?
Yes, sir. If it is two conditions, sir. One is pulmonary hypertension, Eisenmenger, or ASD even without pulmonary arterial hypertension.
Yes. If there is a significant dilatation of the pulmonary artery hypertension, and the apex is formed by the right ventricle, sometimes the pulmonary click can be audible at the apex also. So if the apex is formed by the right ventricle, then there's a possibility that you may be hearing the pulmonary click even at the apex. But usually it is the aortic click which is audible at the apex. The pulmonary click is very unlikely to be audible on the right side of the sternum. So if the click is audible on the right side of the sternum also, then you should go for aortic click. And if it is purely restricted to the left side of the sternum, it could be both aortic as well as a pulmonary click. But then you have to look at the scenario in which you are hearing the click. So a patient with aortic click, you may be able to hear at the pulmonary area, on the right side of the sternum, or even at apex. While the one with the pulmonary click, usually it is audible on the left side of the sternum only, not on the right side of the sternum. Okay, go ahead. Murmurs.
Murmur, sir. First murmur, mid-systolic ejection murmur in a pulmonary area, rough medium pitch, no conduction, grade 2/6.
Okay.
Early diastolic blowing, high pitch.
Sir, so this is pulmonary click only, no? This click is.
No, I do not know, because at the end of after hearing everything, we have to draw a conclusion.
Okay.
Second murmur is in early diastolic blowing, high pitch, short murmur, best audible in the second and third left intercostal space close to the sternum. No change with breathing. Better audible in the sitting and leaning forward position, grade 2/6. No other murmur.
Other systems,
Other systems, respiratory system, trachea slightly deviated to the right, pectus carinatum present, no advential sounds heard over the lung fields. Abdominal examination, liver palpable 2 cm below the right costal margin, gastric tympanic note on the left side, spleen not failed, no ascites. Central nervous system examination, there is upper motor neuron palsy, paralysis of a left upper limb.
No, it's always important to examine the abdomen in all patients with cyanotic congenital heart disease or any congenital heart disease to decide the situs, because sometimes that will give you the
Situs.
always look for, don't forget to examine the abdomen carefully for the viscera in order to decide what is the situs. So that is extremely important to make the correct diagnosis. So now coming to discussion, you have to draw a conclusion. What is the reason for the murmurs and what is the reason for constant ejection click?
Yes, sir. There is a constant ejection click in pulmonary area plus mid systolic murmur. Ejection murmur is in pulmonary area. So I will think of pulmonary stenosis. Then early diastolic growing high pitch murmur.
Grade 2 by 6.
It's a grade 2/6 murmur.
That's not a very loud murmur.
Maybe flow murmur, sir.
Do you have any other explanation?
Flow murmur, sir.
Flow murmur. Flow murmur for the moment there should be increased flow. Can it be something else? For that we have to ask a question. What is the mechanism? So the mid-systolic murmur is the ejection murmur is the commonest murmur which is audible over the precordium. What are the 6 mechanisms of production of mid-systolic ejection murmur? Sagar?
One is outflow tract obstruction.
Okay, obstruction. Normal flow through a stenosed valve. 1, 2.
Stenosed flow. Normal flow is
normal flow.
Then supravalvular, infravalvular.
No, that's all right. Normal flow through a stenosed valve, either intravalvular, valvular, supravalvular, all are same. Another mechanism.
The normal valve.
Flow through the normal valve.
Increased flow through the normal valve. Example, in a patient with
flow through the normal valve.
Yes, it can occur in ASD, it can occur in aortic
hyperdynamic condition.
Then the third is hyperdynamic circulatory stage, can give rise to a mid-systolic ejection murmur. Yes, in hyperdynamic you cannot use the word increased flow. It is actually increased ejection. Right? Okay. Yes. Other mechanisms. Another is no obstruction, but there is a structural abnormal valve, as can occur in patients with bicuspid aortic. And another is sclerosed valve. Patients with the sclerosed valve can have a mid-systolic ejection murmur. And finally, the one which is here may be because of the vessel is dilated, as somebody has already said. If the valve is opening to a dilated vessel, that can result in a mid-systolic ejection murmur. So there are different mechanisms for production of the mid-systolic ejection murmur. Usually, if it is due to an obstruction, usually the murmur will be loud. It will be 3/6, or if it is associated with thrill, you classify as 4/6. Here it is 2/6. So chance of a pulmonary stenosis not very high. You can even consider that it may be because of the
pulmonary dilatation.
Pulmonary dilatation. Okay, right. Yes. What would be the
pulmonary dilatation?
Yes, pulmonary artery dilatation may be the mechanism. And what is the early diastolic murmur? Blowing high-pitched murmur.
The diastolic murmur.
Pulmonary regurgitation murmur.
It can be pulmonary regurgitation. Very good. It's 22 years. 22 years. There is a possibility that it may be even aortic regurgitation. But I agree with you that if we have to go with our diagnosis of a patient has gone in for Eisenmenger reaction over a period of time, then we have to consider the possibility of pulmonary regurgitation. Okay, right? Yes. So putting all put together, because we have to go for X-ray, ECG, and also echo. What do you think is your provisional diagnosis? Is the patient
cyanotic congenital heart disease?
Yes.
high pulmonary blood flow group.
Yes, very good.
Probably transposition of great arteries.
Excellent.
With associated right to left shunt.
I mean, there's a right to left shunt. Okay, you transposition is enough to give rise to cyanosis, but you can give you can always tell that the patient is having pulmonary arterial hypertension because the second sound is single, loud, all put together pulmonary arterial hypertension, and you are explaining the two murmurs with the help of the pulmonary arterial hypertension. Would you like to do you want to consider any differential diagnosis?
Sir, do we need to mention regarding that there was history pus from the brain?
Hyperviscosity.
So that can be abscess or anything.
Oh, that has to be mentioned. Oh, yes, he had a brain abscess and he developed
yes, sir.
The upper neuron.
That is why he is having upper neuron. Yes, sir.
Yes. So that you have to include that.
And history of intervention also, sir. History of intervention also.
That also should be mentioned. He most likely has undergone a atrial septostomy, and also he has got evidence of brain abscess, which has resulted in upper neuron type of facial.
And hyperviscosity with venesection.
Yes. Okay. So all put together, I think our full diagnosis would be Sagar. Once more, full diagnosis.
Cyanotic congenital heart disease, high pulmonary blood flow group, probably transposition of great artery physiology.
Yes.
With the pulmonary artery hypertension associated
pulmonary regurgitation,
cerebrovascular accident.
Not cerebrovascular accident. Why did you say
pulmonary regurgitation?
Not cerebrovascular accident. He had a cerebral abscess. Because he said that there was pus in his brain. So there is a cerebral abscess, and also he has undergone an atrial septostomy.
Atrial septostomy.
Yes. Okay. So now
at the age of 4 months.
Any other differential diagnosis you would like to consider?
Normal sinus rhythm.
Very good. And if you want, you can say that no evidence.
Normal sinus rhythm, no infective endocarditis.
No evidence of infective endocarditis. If you want, you can include that. Okay. Right. Now we'll go to the ECG and X-ray. What would you like to see first, ECG or X-ray? Okay.
X-ray, sir.
You want to see the X-ray first? Why do you want to see the X-ray first? This is the X-ray. What is the what is your interpretation of the X-ray?
So this is a chest X-ray PA view.
Okay.
Well centralized. Exposure is good exposure.
No, it's super. So it's exposure. It is actually the exposure is still little more than normal. Over penetrated exposure. Because over penetrated exposure, because you can prominently see the spine, even in the intervertebral space is clearly seen, indicating that it is slightly over penetrated. When there is an over penetrated X-ray, that is a poor X-ray for interpretation of the pulmonary vasculature. You may not get a clear picture of the pulmonary blood flow, the pulmonary vasculature. That is the one disadvantage of slightly over penetrated X-ray chest. Okay, right? Yes. Okay, go ahead.
There is a
NP type or RV type?
Slight cardiomegaly.
Yeah, there is a minimal cardiomegaly. Yes.
This is RV type, sir.
Why did you say that?
RV type apex.
Why did you say it's RV type?
We cannot confirm, sir. In this review, we cannot confirm it's RV or LV.
You cannot be certain about it. I will never go for RV. If at all, I would go for only LV. Because RV means that it should be lifted up and there should be an acute angle between the diaphragm, cardiac shadow and the diaphragm. So here
it is actually dipping down, sir. Here it is dipping down.
Actually, sir, this patient is on kyphoscoliosis. So
yeah, I agree with you that the interpretation is difficult. But if at all I am to interpret I will go for an LV type of apex rather than RV type of apex. Okay, right. Yes. Pulmonary vascularity is it normal or increased?
Okay.
What is the aortic arch? Is it to the
Increased,
right?
sir.
Aortic arch is it to the right or to the left?
Aortic arch is on left side, sir.
Yeah, aortic arch is on to the left side. You can see the indentation is seen to some extent. So it seems to be a
Intended.
left side aortic arch. What is the percentage of patients with the right side aortic arch in various congenital heart disease?
Top 25%.
Okay,
Truncus artery is 40%.
very good.
Sir, absent pulmonary valve is 50%.
Yes, pulmonary atresia is 30%. Yes,
Sir, absent pulmonary valve.
absent.
top-
You said pulmonary atresia.
No, sir, absent pulmonary valve. Trough with
Oh, absent pulmonary valve. In tetralogy fellow. Yes, yes,
trough with
okay.
absent pulmonary valve.
Yes, yes, okay. And but absent pulmonary, what is the percentage? I do not know. What is the percentage?
Sir, I think 50%. It is very high.
Oh, I see. Oh, I did not know that. You have to verify that. My impression is that the highest percentage in a patients having right side aortic arch, the commonest is not commonest. The highest percentage is truncus arteriosus. Commonest patients having the right side aortic arch is the tetralogy fellow because that's 25%, and the tetralogy fellow patients are much more than truncus arteriosus. So percentage wise, it may be less than truncus arteriosus. But if you look at the prevalence wise, that will be a tetralogy fellow.
Sir, I will check it. Sir.
Okay. So VST, can there be a right side aortic arch, and what is the percentage? In transverse to great arteries, can there be a right side aortic arch? What is the percentage?
VST 5 to 10%.
Yes, less than 5%. Less than 5%. And in truncus arteriosus, it is about 5 to 10%. Transverse to great arteries, it is 5 to 10%. So still in transverse to great arteries, you can sometimes get right side aortic arch. Here the arch is left sided. Okay, go ahead. Pulmonary vascularity.
Vascularity as
What is the X-ray which will give you a clue to the diagnosis of transverse to great arteries?
Narrow pedicle, sir.
Very good. Narrow pedicle. Is there a narrow pedicle here?
No, sir.
No.
Yes, sir.
No. There's no narrow pedicle at all. I think the pedicle is normal. It's normal. So from the X-ray test, I would think that there is no clue to diagnose of transverse of great arteries. And what about the pulmonary vascularity?
Right.
Increased. Pulmonary vascularity is slightly
Increased pulmonary.
Yes, because even though it is a over-penetrated film, you can definitely see that there is some degree of some endon vessels are seen, indicating that increased pulmonary vascularity. That is a point in favor of truncus or transverse to great arteries. Okay, now we'll go to
Fissural effusion also we can see, sir. Fissural effusion is we can see. Right side, right horizontal fissure, some effusion is.
There is some, okay, partly seen, okay. That's usually
Coronal angle is increased, sir.
Coronal angle.
Normal, sir.
Also, kyphoscoliosis है ना तो comment.
Yeah, kyphoscoliosis is there. So whenever there is kyphoscoliosis, there is some limitation. There is a kyphoscoliosis, so there is some limitation that can also interfere with your narrow pedicle, everything. So there is always a limitation when there is kyphoscoliosis. Okay, the X-ray does not strongly favor transverse to great arteries, but it's not against. ECG. Sagar, you interpret the ECG?
12 lead ECG, normal standardization, normal sinus rhythm, ventricular rate of around 100.
Yes, that is borderline, maybe little less than 100. Okay, right.
Extreme axis deviation
What is the axis? Where is the
Extreme axis deviation.
Where is the axis?
Is extreme axis.
What is the axis?
Yes, sir. Minus around minus 120, sir.
Okay. The transition is transition is from lead 1 to AVL. So it is beyond minus 90. So in the right upper quadrant. Very good. Yes. What else? Any right atrial enlargement?
Yes, sir. Right atrial enlargement.
Okay. And what about on the is there a right ventricular enlargement, left ventricular enlargement, biventricular enlargement?
It's a left ventricular enlargement.
Why?
No.
Biventricular hypertrophy.
Biventricular enlargement.
Why did you say biventricular?
The persistent of in the V6, sir, we can see the tall waves, and V5 and V6, sir, tall waves are seen.
But that should be in mid-ventricular, sir, for biventricular.
There is definitely right ventricular involvement. There is no doubt about it. Left ventricular borderline, because the tracing is not really good to separate out the height of the R wave and the depth of the S wave.
And sir, so suprasystemic RV pressures we can say, no, sir?
Beg your pardon?
Suprasystemic RV pressures.
Because there is a, if you want, you can put it as there is some STT changes, so RV pressure is significantly elevated. But when there is RSR dash pattern, usually when there is a suprasystemic RV pressure, it will be a QR pattern. And with STT changes. Here it is an RSR dash pattern. So that will not definitely, it usually indicates that there is a volume overload of the right ventricle, and you can't be certain about the suprasystemic RV pressure. I will not comment on that.
Sir, right atrial enlargement can
maybe there is a biatrial enlargement.
sir?
There is right atrial enlargement, there is left atrial enlargement. Very good.
And transition from V2.
Yes. From V1 to V2, there is a transition. What does that indicate?
Large VSD, non-restrictive
usually,
VSD.
Non-restrictive VSD, and classically occurs in patients with pathology of fellow. Okay, yes. So here, only the axis is the only one which makes us suspect that there is an abnormal axis, but otherwise we can't be certain. Okay, let's go to the echo. Echo is slightly difficult.
Sir, it is like a transposition physiology.
Right.
Sir, in the third view, both the great arteries are parallel, and sir, the artery which is sir more dilated looks like whether that is bifurcating.
Okay, there is the large vessel seems to be bifurcating.
And sir, on the left of it, the vessel which is parallel maybe sir pulmonary artery.
No, this one.
Yeah, sir.
And I can't see a valve there, so I have to see a valve. In a transposition, you would expect the pulmonary valve to be posterior, pulmonary artery to be posterior, and the aorta to be anterior. So you must be getting the aorta onto the right side, this side.
Yes, sir.
Onto the.
Yes, sir. Yes, sir.
So here you have to find out which. I agree with you that there is a strong possibility that this could be bifurcating. If you look at this vessel, this is a large vessel. It's coming here. It seems that it is dividing into two.
But sir, in parasternal short axis view, you see aorta and PA appears to be with normally
that saucer view.
Short axis. That aorta and pulmonary artery are maintaining their
no, in the short axis they are not maintaining. We can see both the valves in the upper right one. We can see both valves together in a circular form.
You can see actually this is a, if you want, you can interpret that this valve is anterior, Normally, you'll expect the pulmonary valve to be here, and here it is anterior, indicating that this vessel is abnormally anterior to this vessel. But if you look at here on the third one, there's definite reason for you to believe that this large vessel is a pulmonary artery because it divides into two. Can you see this division?
Yes, sir.
There is a division. Okay, let's go to the next one. It's a slightly difficult echo.
Sir, can you explain what happened in that short axis view, sir? Is it looking that central is the aorta and that above is the pulmonary artery, sir?
This one here. No, I do not know. I have
Here
to,
we cannot say. We
yeah.
cannot say.
This
You
one,
can
sir,
only
yes.
say that there is an anteroposterior relationship.
Yes.
Because normally the pulmonary valve will be slightly onto the not that anterior, it will be
Yes, sir.
slightly onto the left side. So here actually this artery is mostly posterior, and you can see another valve which is anterior. So if you look at here, you can see that the valve, the large artery which you are seeing here actually is dividing, and hence most likely this is a pulmonary artery.
Okay.
So VSD we can say with confirmation, sir. VSD is there, that we can.
And sir, one more thing, sir, in plaques view also, sir, we cannot see that that aorta usually, sir, curve around, no? That is not curving, sir. So in the plaques view. Yeah, first view, sir.
That can be taken as a, but when he has got kyphoscoliosis and all, there is a limitation. But this division will definitely tell you that this is the pulmonary artery. Okay, now we'll go to the next one. So it's a very difficult issue.
Sir, interatrial septum shows some deficiency. Maybe, sir, that atrial septostomy was done.
Yeah, there's a good, mostly
echo drop is seen, sir.
From the left to right.
Yes, sir.
And also there is an indication that there may be some bidirectional flow because there's some blue color also.
Sir, blue also coming. Sir, this is bidirectional.
Yeah,
mostly and sir, here, LA is very little more prominent, sir.
Yeah, LA is more prominent, and there is more of a left to right shunt. But there is a possibility that there is.
And sir, there is a VSD can be seen in the right upper.
Yeah, that's a VSD. What type of VSD?
Muscular, sir. Looks like muscular.
It looks like a muscular VSD. Very good.
And sir, it is, sir.
There's a muscular VSD. Okay, right? Yes. We'll go to the next one. This is actually a frozen frame to show that this is the pulmonary artery which divides into two, and you can see the VSD here. It's a muscular VSD. This is a large ASD. You can see mostly it is a left to right flow. You can see the large ASD here. It is not. You can see the flow here. You can see some bidirectional flow, blue as well as red flow, indicating that there is a large ASD. And this must be the effect of the atrial septostomy the patient had when he was 4 months of age.
That was very good procedure, sir. It still flow is maintained.
Yeah, the excellent procedure. Here you can see
sir, LV is dominant, appears to be LV is dominant here, sir, in echo-wise if you...
Yeah. LV.
So our palpation of RV type apex...
Let us look at the four-chamber view slightly better. Okay, interpretation. I agree with you that LV, which is LV of this, which one is LV?
Sir, sir, LV on the normal position, sir.
Okay, yes, LV is in the normal position. And so this is LV, and this is LV, this is RV, this is the VSD. So let us look at other views. There's a The flow is in through the VSD. What is the type of flow? Is it left to right or right to left?
Left to right.
Left to right flow. Very good. Excellent. It's a left to right flow. Again, that you can see it very clearly here. There is a VSD, muscular VSD. There is a mostly it is a left right flow. I don't know whether it is a bit of a right left flow also, but mostly it is a left right flow. Not a very large VSD. It is a average sized VSD, not a large one. And usually this is not the classical VSD of in a patient with a prodigy fellow or in a patient with a transpositional data arteries. Very often it is a symbiotic or subpulmonic VSD, where this is a muscular VSD.
And sir, there is some regurgitation from this great artery also.
Yeah, there's a
I'll say
regurgitation.
it is a restrictive VSD, sir. I will say it is.
Yeah,
We'll say restrictive VSD, sir.
it's a restrictive VSD, and there is a regurgitation coming from the.
So what is the pressure around this? The pressure around the VSD? You have not.
I do not know. I don't remember. I agree with you that there is a VSD from left to right, and there is some degree of regurgitation, which is a pulmonary artery which is connected to the left ventricle, and there is a regurgitation of the pulmonary valve. So pulmonary regurgitation.
Yeah. Sir.
Here you can see the two vessels. You can see here, you can see the two vessels. One is this is the pulmonary artery, and here is the aorta. The blood is flowing through this vessel. It is only partly seen. The pulmonary artery is definitely very large, and you can clearly see it.
So aorta
There is a very difficult. It was very difficult for me to look at the different relationship. But one view which we saw previously, where the second semilunar valve is anterior to the larger one. So I thought that will be a clue for us to think that the aorta is anterior and the pulmonary artery is posterior, and you are able to see the large pulmonary artery and its valve posterior to the aortic valve. This was actually a really difficult effort to.
mitral wall thickening is also there. Mitral wall thickening is also there. Mitral wall thickening.
Mitral valve?
Mitral wall thickening is
Yeah,
more than 5 millimeters of this mitral wall.
There's some degree of mitral valve thickening. I agree with you. Okay, now coming to the diagnosis and a short discussion about. Okay, Sagar, the diagnosis.
Final diagnosis: congenital cyanotic congenital heart disease, situs solitus, leocardia,
Detransposed to great arteries.
My screen.
What happened to your
cyanotic congenital heart disease, situs solitus, leocardia, detransposition of great arteries with atrial septal defect, bidirectional shunt, small muscular VSD, left to right shunt, severe PH, SM Menger syndrome, pulmonary regurgitation mild, no heart failure, previous balloon septostomy.
Okay, and also we should add the patient had brain abscess, and consequent to that, patient had upper neuron type of brain abscess and upper neuron type of left hemiparesis. Okay, so a few discussion about transposed to great arteries. Can you read this? I don't know this. Can you read this, Sagar? If you read transposed to.
Yes, sir. Yes, sir. Yes, sir. Transposition of a great arteries. Left ventricle give rise to pulmonary artery, and right ventricle give rise to the aorta.
That's the most important. But transposition means transposition means LV is attached to the PA, LV is connected to PA, and RV is connected to aorta. Right. Okay. Yes. Right. Two types.
So transposition of two types: detransposition of great arteries, L transposition of a great arteries, also known as a corrected transposition of great arteries, as there is a physiological correction of a blood
flow. Okay.
blood flow.
Yes.
Dextro transposition of great arteries. In that right ventricle, blood goes to the RV, which is connected to the aorta. So the impair blood to the systemic circulation. Left arterial blood goes to the left ventricle and pulmonary artery. So pulmonary blood flow to the pure blood to the lungs.
Okay.
So simple transposition, two-thirds of the patients have no other major cardiac anomalies.
So in
Complex transposition, 1/3.
You go ahead. Complex transposition.
Complex transposition, 1/3 of the patients have other cardiac anomalies, like commonest is VSD.
Okay.
In DTJ, two
circulations, pulmonary and systemic.
Two connections. Two circulation, pulmonary and systemics, are connected in a parallel manner and not in a series. This arrangement is not compatible to the life. Hence, communication between the two circulation is essential. Treatment 30.
Without treatment.
30. Without treatment, 30% die within the first week and 90% die within 1 year. Clinical findings: cyanosis from the birth, tachypnea present, no other features of congestive heart failure. First heart sound normal, second heart sound single. Murmur depends upon the associated lesions like VST and LV-RV outflow obstructions. ECG, abnormal QRS axis and RVH. X-ray, absent thymus.
The absent thymus shadow,
agon side appearance. Absent thymus with the agon side appearance. Narrow pedicle, pulmonary plethora in the patients with a VSD and ASD.
Okay.
Echocardiography, RV is connected to the aorta and LV to the pulmonary artery. Subaortic conus. VSD, ASD, if present, can be detected. Treatment, interventricular treatment. Interventional treatment, balloon atrial septostomy. Surgical treatment, atrial switch procedures. Redirection of blood at the atrial vessel using a baffle. Venous blood goes to the LV and oxygenated blood goes to the RV. Mustard procedure, baffle made of dacron or pericardium. Sending procedure, baffle made of atrial flap. Complications of this procedure, systemic RV dysfunction 40%, atrial rhythm disturbances, sinus node dysfunction, significant tricuspid regurgitation in 10 to 40% patient, pulmonary venous obstruction, SVC and IVC venous obstruction. Other procedure is arterial switch procedure.
This atrial switch surgery has got a number of complications, which most important is that systemic RV dysfunction, because the RV is connected to the systemic artery, aorta, and it will not be able to generate enough pressure to pump blood into the aorta. So by about 15 to 20 years, 40% of patients who have undergone atrial switch surgery develop RV dysfunction and RV failure. The atrial rhythm disturbances are very common because when they do the baffling, that may damage the atrium, and that can result in various atrial arrhythmias, starting from atrial tachycardia to atrial flutter fibrillation. And sometimes during the procedure, sinus node may be damaged, and that can result in sinus node dysfunction. Because the RV is exposed to the systemic circulation, systemic pressure, these patients can have tricuspid regurgitation in almost 40% of them. During baffled surgery, sometimes it can result in pulmonary venous obstruction or systemic venous obstruction, and the patients can have acute pulmonary edema or severe pulmonary congestion or patients can have systemic congestion also. So the atrial switch surgery is associated with a number of complications, and at the moment it is becoming more and more unpopular, and the present surgical procedure is Sagar.
Arterial switch.
Arterial switch surgery, yes. What are the problems of arterial switch? You read about that?
Yes, sir. Arterial switch procedures. Arterial trunk are connected and are re-anastomosed. Coronary arteries are transposed to the new aorta. Complications are aortic regurgitation, pulmonary wall.
It is a pulmonary valve.
Usually mild.
And also
osteocoronary artery disease.
Yeah, these patients, because when the coronary arteries are reimplanted, sometimes there can be sometimes minor injuries, and that can result in coronary ostial stenosis. So these are the two complications, but they are not very significant, and usually this is a very successful and effective procedure.
Prosthesis procedure for an infant with TGA, VSD, and LVOT obstruction, extra cardiac conduct from RV to PA. Poor outcome may require repeat procedure. Pulmonary artery banding not being done now.
This is previously it was being done in order to reduce the pulmonary blood flow, but nowadays it is not being done because the preferred treatment is total correction. So either arterial switch and VSD closure all can be done at the same sitting, and nowadays the pulmonary artery banding is not a recommended procedure. So for surgical treatment, most important is the arterial switch, and atrial switch, which was being practiced previously, is becoming more and more unpopular. Rasterly procedure, which can be reserved for patients with transmissional data arteries, VSD with LV outflow obstruction, has a bad prognosis because they may require the complication rate is very high and may require a repeat procedure. So just small few points about the transmissional data arteries. If you have got any doubt, you can ask now, or otherwise we will stop.
Sir, initially we discussed that there will be high volume pulsing cyanotic, in all cyanotic congenital heart disease.
In general, cyanotic congenital heart disease, depending upon the cyanosis, can have a higher volume pulse. Depends upon the gravity of cyanosis. Transpositional great artery is the one which can give us the severe cyanosis, and so that is the one which will have a striking high volume pulse.
So, sir, one question you asked, sir, about TOF. What is the mechanism of a single second heart sound in TOF?
Oh.
So,
what is the mechanism?
So, in that, sir, again, because of the atrial.
Because of the?
Sir, aorta is related.
Severe pulmonary stenosis.
Yeah, it is because of the severe pulmonary stenosis, and also that will result in a very feeble closure of the pulmonary valve, and you may not be able to hear the closure noise of the pulmonary valve. And because of the large VSD, the aortic valve closure and the pulmonary valve closure occur almost together, and the aortic valve closure is a much louder noise, and hence the feeble pulmonary valve closure may not be that much audible. And another mechanism is the in pathology of Fallot, the pulmonary arteries relatively slightly more posterior than normal. May not be not that much posterior, but it can be slightly posterior because the aorta becomes large. Aorta takes up the anterior portion, and the pulmonary artery can be slightly posterior, and that can also make the sound less audible. So there are multiple mechanisms to make the sound less audible, and that is why you hear only single noise, and the one which you hear is the loud aortic noise.
Good evening, sir.
Yes.
I am Dr. Vishnu from Tirunelveli Medical College.
Okay.
You mentioned that subaortic conus in echocardiography. What does it exactly mean, sir? I don't get that.
Subaortic conus, yes. How do you recognize subaortic conus? Any one of you? How do you recognize this?
We have to see for the aortomitral continuity.
Yes, you look for aortomitral continuity. That is how you see when you are normally there is a continuity between the anterior mitral leaflet and the posterior aortic leaflet. So this continuity is lost and there will be tissue in between. That indicates there is a subpulmonic conus. Subpulmonic conus is recognized by finding a tissue between the aortic valve and the aortic valve and the mitral valve. And in transposition, what is that valve which is separating the aortic valve?
Tricuspid valve.
Tricuspid valve. It is actually the atrioventricular valve is tricuspid valve, and the aortic valve, of course, there will be a tissue between the aortic valve and the tricuspid valve, and that is the subaortic conus.
Thank you.
Okay, I think we'll stop at that level. Next class, what shall we have? Should we have some hemodynamic data discussion? Or you want spotters? Okay, we'll have some hemodynamic data discussion, and next class will. Next class, whether this next Friday, sometime there is a possibility that I have an engagement. And in that case, next class will be 2 weeks from now. And if there is no class on next Friday, I will let you know sufficiently early so that you won't have any problem. Okay, right. Good night.
Okay, thank you, sir.
Good night. Thank you.
Thank you, sir.
Good night.
Thank you, sir.
Thank you, sir. So with your permission, shall we conclude this meeting?
Yeah, you can conclude.
Okay, thank you, sir. So from here now, I'm ending this meeting. Good night, sir.
Bye, good night.
Thank you very much, sir. Good night.
Thank you, sir.